Welcome to Fibroid Summit 2021. We are so glad that you've joined us. I'm Sateria Venable, founder and CEO of the Fibroid Foundation. Our co-host for today's summit is the Campion Fund, led by Dr. Phyllis Leppert, whom I'll be introducing you to in a moment. Today and tomorrow, we'll hear from 5 leaders in fibroid research. At the Fibroid Foundation, part of our mission is to provide science-backed information to inform your treatment journey. In my role, I often attend scientific conferences and have an opportunity to learn about groundbreaking studies. I've had a desire to make that body of knowledge available to our community as well. That is where the Fibroid Summit idea was born. When we're not all sheltered at home from a pandemic, we host Fibroid Talks in person. The goal of Fibroid Talks are to create a welcoming space where patients and physicians can converse in a casual setting. There's tremendous power in patient-physician dialogue and collaboration. The Fibroid Summit is our virtual attempt to create that environment, and we hope that you will jump right in with your questions. To elevate the dialogue, we'll spend about 30 minutes after each presentation sharing your questions with the presenters. We've gotten some fantastic questions via social media, which we will share as well. As we look ahead to the future of fibroid research, we'll explore new ideas that are emerging. Listen carefully to your comments about the information that will be shared today. And of course, we will provide information on current therapies. We've carved out about 3 hours today and tomorrow for our time together. We hope it will be meaningful, and I personally can't wait to hear your feedback. So now I'd like to introduce our co-host, Dr. Phyllis Leppert, Board Director of the Campion Fund. Phyllis?
Hello. Welcome to the Fibroid Summit 2021. I'm Phyllis Leppert, President of the Campion Fund and Emerita Professor of OBGYN, Duke University School of Medicine. I have been involved in the clinical care of women with fibroids for 40 years and in the research of fibroids for over 30 years. The Campion Fund supports fundamental research for reproductive health, and we are pleased to co-host the Fibroid Summit 2021. We believe in the importance of dialogue between physicians, scientists, and the individuals we ultimately serve. For this reason, the Fibroid Summit is providing time for extended discussion following each of the presentations. Uterine fibroids, benign, non-cancerous growth, are complex tumors. Each one is different from all the others. As scientists, we call this heterogeneity. You will hear about heterogeneity throughout the next 2 days. Research has shown that one fibroid in an individual uterus is different from all the other fibroids in that uterus. Also, within a fibroid, there are differences between various parts of that fibroid. Some fibroids are large, some are small. One woman will have multiple fibroids. One woman will have large fibroid. Some shrink. They appear to grow at different rates. They can produce a variety of debilitating symptoms, but some have no symptoms at all. This heterogeneity or difference has been a challenge as we work to understand what triggers fibroid initiation and growth. It is why we struggle to figure out exactly how they can regress on their own. Heterogeneity has also made it difficult to develop and study fibroid treatments. Recently, major progress has been made in our understanding of fibroid biology, and new treatment options are becoming available. The Fibroid Summit speakers will share this new knowledge with you. Keep in mind that science is a process. Scientists ask the question, how do we know what we know? New discoveries are constantly being made. These discoveries are presented to other scientists and then discussed with them. Then ideas coming from these discussions lead to new studies, new possibilities for treatment. In this manner, science advances. The scientists presenting at the Fibroid Summit are accomplished and knowledgeable. We hope you will listen to them carefully, ask questions, and make comments following the talks. Dialogue is important. This is how we make progress. Before I turn the meeting over to our presenting sponsor, I want to thank the Fibroid Foundation, Sateria, Karen, Brittany, and Emma. I also want to thank Kevin Bryant from Evolve Marketing and Media for his role in the production of the Fibroid Summit 2021. Now you will hear from Juan Ferreira, Medical Director of Myovant, the Chief Medical Officer of Myovant.
Hello, and thank you to the Fibroid Foundation and the Campion Fund for convening this important forum, the first Fibroid Summit. I'm Juan Camilo Arjona, Chief Medical Officer at Myovant Sciences. Myovant is proud to be a presenting sponsor of this event, and we are honored to be part of this landmark gathering, the first of its kind. While we all would prefer to be discussing these topics in person, this virtual format enables us to connect in new ways and, I believe, can enhance our understanding and our ability to listen and share our thoughts and ideas. So I'm looking forward to this important dialogue about uterine fibroids and how we change the outlook for patients in the future. I have been working in women's health for most of my career, both as a practicing gynecologist and with companies developing new medicines. While many things have changed and we have seen great progress in some areas, some things have remained fundamentally the same. There remains, for example, limited innovation and new medicines for diseases which impact women, falling far behind other therapeutic areas despite the fact that women make up 50% of the population. These diseases also remain largely in the shadows and left undiscussed and stigmatized by the broader population. These realities are unacceptable and demand urgent change. At Myovant Sciences, we're committed to bringing innovation to women's health and are currently working on new potential medicines for uterine fibroids and endometriosis. But that is not where our work ends. We believe science and medicine must be coupled with compassion and advocacy, an authentic and inclusive caring for and partnership with the patients we serve. In fact, Myovant was founded on 3 pillars: purpose-driven science, empowering new medicines, and transformative advocacy. Ultimately, our goal is to redefine care for women, which we know has to be accomplished through collaboration with other individuals and organizations like each of you. This is why, soon after starting the company, we formed a cross-sector coalition with other organizations called Female Forward Together, focused on elevating the conversation around menstruation and advocating for improved research funding and innovation in women's health. A key part of this effort is enabling women to speak openly about their experiences, free of shame and taboo, so that no one has to suffer in silence. As an example, we recently launched a video storytelling series with healthy women called Voices of Periods, in which women share their experiences with menstruation. This kind of work has helped us more deeply understand what women with uterine fibroids, for example, have experienced in their personal journeys. These insights have reinforced for us the importance of conversation between women and their researchers and physicians, pushing ahead the science that, when combined with advocacy, can create a new tomorrow for the uterine fibroids community. Over the course of the Fibroid Summit, we will be hearing from some of the world experts on uterine fibroids, including Dr. Ayman Al-Hendy, Dr. Stewart, and Dr. Sunny Singh. This is an incredible opportunity for all of us to learn about the latest science on this disease. This is also a unique opportunity for all of you to raise your voices and to inform the future work of these scientific leaders. So today, I encourage you to embrace your individual and collective power to drive progress and share, to tell your stories, share your perspectives, and participate fully in this important event. It is only through openness, candor, and honesty that we begin to overcome the stigma around uterine fibroids, and in turn, enable the groundbreaking science needed to understand and treat the disease. At my event, we're so grateful to the Fibroid Foundation and the Campion Fund for their leadership in creating this needed forum for conversation. We are excited to learn alongside each of you over the course of the day. You have our commitment to continue supporting these activities, and together we make progress toward making a change for women with uterine fibroids.
Today's first presentation will be from Dr. Ayman Al-Hendy. Dr. Al-Hendy is a professor of obstetrics and gynecology at the University of Chicago. Welcome, Dr. Al-Hendy.
Hello, this is Ayman Al-Hendy. I'm a professor of gynecology at the University of Chicago. And I would like to start by thanking Ms. Soteria Venable, the founder of the Uterine Foundation, and also Dr. Phyllis Lippert for the kind invitation and for the opportunity to talk at this important meeting and for really putting this important gathering together. The assigned title to me is Uterine Fibroids, Current Understanding of the Basic Pathophysiology. These are my disclosures. So the objectives of my talk today is to give you some general introduction and also talk about the classification of uterine fibroid, the current one, and if there's a room for improvement as well. Then the bulk of the talk really will focus on the risk factors, who actually does get uterine fibroids. And we always used in our research program these risk factors based on very well done epidemiology studies, etc., to drive the basic science, to drive our attempt to understand the pathophysiology of fibroid. And then I will end up by touching on knowledge gaps, unmet needs, and some future directions, although I recognize that limited time. So some of the exciting data in that area, hopefully we can cover in the question and answer period. So uterine fibroids. So for this audience, I think we're all very familiar with uterine fibroids, which are also called uterine leiomyoma. They are benign. They are benign smooth muscle tumors originating from the wall of the uterus, from the myometrium. So in this diagram, this pink area here, this is the wall of the uterus, this is the myometrium, and fibroids start from stem cells in this tissue. And I'll come back to that. It's by far the most common human tumor in reproductive age women. In some autopsy studies, up to 77% of all women had fibroid lesions. Luckily, only around 50% of those actually do develop symptoms and seek medical help. But that's still a large number of women or patients. So uterine fibroids is by far the #1 indication for hysterectomy in the United States. And in my opinion, we honestly do too many hysterectomies. In the US, we do about 600,000 hysterectomies every year. The majority of those are due to uterine fibroids. This is about double the number of hysterectomies done in Germany per population after you adjust for the total population, and about 5 times folds more than what they do in Canada, again, after adjusting for the total population. So we definitely doing a lot of hysterectomies in the US compared to other developed countries. Fibroid lesions are very variable. They can be from this tiny fibroid here to a fibroid that can be very large, 10, 15 centimeters in size, and and very heavy, more than several kilograms in weight. The largest number of fibroids I've removed from a single uterus, my record is 29, but I know many of my colleagues have removed more than that, especially from women of color, and also some of my colleagues in Africa have seen severe disease. So what are the manifestations of uterine fibroid? What does the patient come to the clinic complain about? Heavy menstrual bleeding is by far the most common symptoms. About 85% of uterine fibroid patients come and complain that their menses is heavy and or irregular. Of course, if this heavy bleeding goes untreated and not compensated, the lost iron not compensated, most of these patients end up with iron deficiency anemia and all their related symptoms such as fatigue, headache, lack of energy, etc. Fibroid also can be a common cause of abdominal distension, pressure symptoms or so-called bulk symptoms, pelvic pain and discomfort, painful menses. Also, fibroid has been connected to infertility, and when the patient eventually gets pregnant, also it can cause some obstetrical complication, such as recurrent miscarriage, preterm labor, and postpartum hemorrhage, bleeding after delivery. So as you can imagine, when you combine all of these important symptoms, uterine fibroid has significant negative impact on quality of life of patients who suffer from uterine fibroid. So how do we classify fibroid? How do we describe them, both in research and to the patient and in the patient notes and so on? Most of the time, we just simply use the location at this point to describe fibroid. So for example, if they're in the wall of the uterus, like these guys here, we call them intramural fibroid. When they bulge in the cavity of the uterus, like this one here, we call it submucosal. And when they start to go to the abdominal cavity, like this one starting to do, we call them subserosal. So it's based on location. FIGO, the International Federation of Gynecology and Obstetrics, developed this numerical system as an alternative numerical system, classification system, so that we can compare research studies done in different parts of the world. But it's also based on location. So if you are totally in the cavity, you are type 0, like this one here. If you are more than 50% bulging in the cavity, you are type 1, less than 50% type 2. If you are totally in the wall, you become 3, 4, etc. I'm sure we all would agree, healthcare provider and patient as well, that this classification system is not ideal. And I think we need better classification system. The reason for that is you can have a single intramural fibroid and you can have lots of symptoms. And you can have several fibroids affecting different parts of the uterus, and you can have no or minimal fibroids. So the correlation between the location and the symptom severity is very poor in case of uterine fibroid. So the location advice really doesn't apply in uterine fibroid. The same thing for the size and the number. So again, you can have a small single fibroid that's protruding in the cavity, and you can have lots of symptoms, and you can have in another patient have multiple fibroid much larger in size and have no or minimal symptoms. So again, with the current classification system, the correlation with size and number is also very poor. So we definitely need better classification system. Some of the exciting work in that area, developing new classification, has a lot to do with the extracellular matrix. I forgot to show you in that previous picture here of this large fibroid lesion here. This lesion or this tumor contains, of course, a lot of fibroid cells, but also a lot of the white stuff here. This is what we call extracellular matrix. It's stuff that's secreted by the fibroid tumor cells and just make the bulk of the tumor, such as collagen, fibronectin, proteoglycan, etc. And this collectively is called extracellular matrix. So a lot of our understanding of how ECM works in fibroid and how do they affect the tumor actually comes from the excellent work done by our organizer, Dr. Phyllis Lippert, and also other pioneers in this area, such as Dr. Jim Seegers, Dr. Bill Catherino and many others, we have now good understanding of how this ECM affect the tumor cells. And it's really a very dynamic relationship. So more ECM makes the tumor, as I showed you in the picture, bigger, and also make the tumor much stiff. It decreases the consistency of the tumor, so it make it more stiff or firm. And then the more stiff you are, the more also you're going to affect the tumor cells, and the cells will proliferate and also produce more ECMs, and you create this kind of physiological loop. So it turned out the amount of ECM affects the tissue stiffness, and that has a lot to do and determine a lot the biology of the tumor. So there has been now some development in the ultrasound imaging world that actually take advantage of that, using a special kind of ultrasound. It's called shear wave elastography. It's a specialized type of ultrasound that we can actually measure in a non-invasive way, measure the stiffness of the uterus, both the myometrium and the fibroid. And it seemed like we can actually gain a lot of information that way, in a non-invasive way. So this is from an excellent paper from a couple of years ago. They looked at the stiffness of the myometrium and fibroid and described a very nice way to measure this in a kind of numerical way. So one of the observations they had, which was very exciting, is that the myometrium, not talking about the tumor, the myometrium itself from a fibroid uterus is much more stiff, right, compared to the normal, to the real normal myometrium. That's actually very interesting, and might have some implication that we can actually predict or be able to know who is actually going to develop fibroid versus not in a non-invasive way. But for the sake of the discussion of the classification, they were able to measure different fibroids and assign them different stiffness. So we are doing actually interesting work in our department in collaboration with Dr. Ryan Longman, the head of our ultrasound services, and hence the AL here, to suggest that we actually might propose a classification based on the tissue stiffness of the fibroid lesion. For example, you might have a soft fibroid, pliable, that means a little bit more stiff, then firm, and then the most stiff will be in that group, the hard fibroid. And we feel that this actually might be a more reflective of the biology of the disease and might correlate better with the symptom severity, although of course we need to do the studies to show that. And we think that using this non-invasive specialized ultrasound, we might be able to assign a special SWE score for the uterus, which might, like I said, correlate better with the symptom severity, might actually be able to better triage patient with a specific SWE score, the specific treatment. And I believe Dr. Sonny Singh is doing interesting work on that, and he might talk about it. He's the last speaker of this event. We also believe that this approach might allow us to predict better in the asymptomatic patients with fibroid who's actually going to develop symptoms and who's going to continue to be asymptomatic. Remember, in my very first slide, I told you only about 50% of women with fibroid do actually end up with symptoms that need or deserve medical attention. And also, by knowing all of this information, that might help us develop a more targeted preventative strategy for those that we know is going to go and develop symptoms versus those who's going to continue to be asymptomatic. So this is an interesting, promising area for translational research. I'm a big soccer fan of Real Madrid, and I like to use them as slide spacers. So now that tells me then I will talk about risk factors for uterine fibroids. And this is just to impress upon you that we actually have quite a good amount of information to know who is actually at increased risk of developing fibroid. And I'll cover this for the rest of my talk, and just to tell you, and you will see soon, that we use this information to drive our basic science agenda in our research lab for the last 20 years or so. So putting these risk factors together, we created this figure. It looks busy, but let me walk you through it. This is part of invited review articles we are finishing now. So these are the different risk factors: unfavorable environmental exposure, especially early in life, estrogen, obesity is a risk factor, vitamin D deficiency. One of the newer risk factors we developed or discovered in our team is the altered microbiome in the uterine area, or in the endometrial area specifically. We believe all of these risk factors contribute to the conversion of the normal stem cell into a tumor-initiating stem cell by producing the kind of microenvironment that's conducive of the development of this mutation, MYT12 mutation, which is by far the most common mutation in fibroid lesions. Once you develop the mutation in the stem cells, you become a tumor-initiating stem cell. And once you actually become a tumor-initiating stem cell, the rest is straightforward. These tumor-initiating stem cells divide, produce more of themselves, and then produce the differentiated tumor cells that grow and make the bulk of the tumor. This is just kind of a list of the different pathways that's altered in a fibroid lesion. We know estrogen and progesterone signaling is altered, and estrogen and progesterone work together to enhance the growth of fibroid lesion. I want to emphasize that progesterone actually does contribute and enhance the growth of fibroid lesion. We know there's altered DNA damage. Certain growth factors, such as tumor growth factor beta, TGF-beta, is an important player. Several other pathways, such as Wnt beta-catenin, are also upregulated in fibroid. And here's again the extracellular matrix abnormal remodeling contribute to fibroid lesion. And we believe this actually happens in two steps. The first hit, or the first step, happens very early in life, even while the baby girl is a fetus inside the uterus. If the mother gets unfavorable environmental exposure at this very early stage and during the development of the uterus, we believe that this normal stem cell become primed or become programmed to become at increased risk. Then these at risk or programmed, reprogrammed stem cell just hang around during childhood, teen years, and even early adulthood. And this constitute the myometrium at risk. And you will see me later call it myo-F. And this just stay on. There's no fibroid yet. But then it depends on the experience of that young individuals and all these other risk factors. If they were unlikely to have these additional risk factors, such as vitamin D deficiency, more exposure to estrogen and progesterone, inflammation maybe because they become obese, more alcohol consumption, unhealthy diet, etc., then the second hit become too much. In addition to the priming that happened together, that lead to the emergence of the fibroid causing mutation, the MYT12. And then, like I said earlier in the previous slide, when this happened, the rest is straightforward. However, even if you are at risk and somehow you mitigate these risk factors and you use measures to kind of balance or oppose this second hit, then you might get away without the rest of your reproductive years without developing fibroid, even though your myometrium might have been already at risk. So I'm going to start talking about some of the very common risk factors, such as we all know that women of color have increased risk of fibroid. African American have about 4 times increased risk. Hispanic women about 2.5 times increased risk compared to European American women. The vitamin D deficiency is another very kind of connected important risk factor. We first published this in 2010, and then since then has been confirmed all around the world. And then certain genetic polymorphic marker, mostly related to estrogen signaling and estrogen metabolism, has been also connected to uterine fibroid. This is from a review articles we published several years ago, comparing Black women versus white women in several diseases. For example, white women are at increased risk of vaginal prolapse or pelvic organ prolapse, on osteoporosis, while Black women or African American women are increased risk of fibroid, definitely, also the aggressive forms of breast cancer and endometrial cancer. And just by looking at this list, all of these conditions are estrogen dependent. In such a way, when you just look at its face value, it suggests that Black women might have more estrogenic environment biologically active in their tissue. That has benefits. So they have less pelvic organ collapse, less osteoporosis, but then it also has a downside because it put them at increased risk of these conditions, which are all estrogen dependent. In relation to that, vitamin D comes into the story. So vitamin D, of course, is a natural enzyme. It's actually an activator of a steroid receptor called vitamin D receptor, VDR. Most of us get our vitamin D from the sun. It's very hard to get sufficient amount of vitamin D from food. So we use the ultraviolet light from the sun, works on the skin, activates certain enzymes, produce the inactive form of vitamin D, which then get activated in different organs, kidney and other organs. So that's right away tells you why women of color or population of color in general with darker skin utilize the ultraviolet less efficiently, and they are at increased risk of vitamin D deficiency. And they are indeed. Vitamin D deficiency is about 10 times more in communities of color compared to their Caucasian or European American counterparts. So we did this work many years ago, and right away it was clear that women with uterine fibroid, this is all based on ultrasound confirmed fibroid. Women with fibroid had less vitamin D in their circulation compared to those in the same ethnic group without fibroid. And we looked at the inactive form of vitamin D and the active form of vitamin D. It's the same actually in European American women. Also, vitamin D deficiency is a risk factor for fibroid there as well. It just happened that African American women tends to have less vitamin D in their circulation. So the prevalence of vitamin D deficiency in general is much more common in African American women, and hence they are at increased risk of developing fibroid. Now, when we looked at women who actually have fibroid, we found that when you have sufficient amount of vitamin D, you end up with a mild disease, smaller volume, just one lesion or a couple of lesions. While if you are severe vitamin D deficiency in that area here, you end up with the more severe disease, larger tumors and multiple tumors. This, like I said, this observation has been confirmed in many other countries all around the world, and more studies are coming regularly. Then the obvious question at that point would be, well, can vitamin D then used as a treatment for fibroid? So this is the Eka rat. You're going to see me talk about her multiple times in this presentation. It's an authentic animal model that develops spontaneously fibroid in the uterus, as you can see here, and the fibroid lesion looks very similar to the human disease. So we actually use vitamin D to treat the Eka rat, and as you can see here, after only 3 weeks of vitamin D treatment, vitamin D was able to shrink uterine fibroid significantly in the Eka rat. And when we looked at the molecular level, most of this beneficial effect is mediated by decreasing proliferation and enhancing apoptosis. Also, vitamin D, the interesting thing about it, it brings to the fibroid area a whole family of compounds that's called vitamin D analogs or vitamin D receptor agonists, such as paracalcitol, which all now become viable options for treatment of fibroid. In this work that we published several years ago, we used one of those, paracalcitol vitamin D receptor agonist, to see if it were able to shrink fibroid in a nude mouse model, and you can see here it effectively and significantly inhibit fibroid growth. So that's very encouraging and promising family of compounds for possible treatment of fibroid. Since our publication, also groups from other countries, here from Italy and from Iran, show that in patient with uterine fibroids and vitamin D deficiency, when you correct the vitamin D deficiency, their fibroid actually shrink. Now, I want to move quickly to another risk factor, weight and BMI. Increased BMI and obesity are risk factors for uterine fibroids. This is from a paper we published 10 years ago. So when we grow the fibroid cells with the fat cells in the same dish, we find that the fibroid cells grow much faster than when we grow them alone. And when we did a lot of addition analysis, it turned out that the fat cells secrete a bunch of factors, we collectively call them adipokines, that stimulate the fibroid tumor growth, which explain why obesity is a risk factor. One of those adipokines is called TNF alpha, tumor necrosis factor alpha. And we know it's a player because when we neutralize TNF alpha, we found that this enhancing effect of the fat cells goes away. Well, can you actually shrink fibroid if you lose weight? I can tell you in the rat, you can. So this is an interesting experiment. We haven't published that yet, that when we take the ECA rat and we expose them to caloric restrictions, so we cut their caloric intake daily by 50%, we see that we can actually shrink the fibroid dramatically. And also the number of fibroid lesions also significantly go down. I'm not aware of any similar studies done in human, but it's interesting that in the rat, a model of fibroid, you can do that. Two important risk factors also, again, is increased risk for fibroid are family history and early age of menarche, which basically speak to more exposure to estrogen and progesterone. Now, I want to emphasize when we have the family history, it doesn't always mean genetics. It could also mean diet. It could also mean environment, because families tend to grow in the same environment and also eat similar diet. So definitely there's a connection between adverse environmental exposure and risk of uterine fibroid. We're all familiar with the DES story. DES is some kind of an estrogen. And women who use DES in the 50s and 60s of last century in pregnancy to treat their miscarriage, the female fetus that got exposed in utero to DES have increased risk of developing fibroid later on. And there's several other data to support that adverse environmental exposure increase your risk for fibroid. And I believe also that could be part of the explanation why minority communities have increased risk of fibroid, because minority communities, unfortunately, tend to be at increased risk for adverse environmental exposure. We did a similar experiment in the same ECA rat that I showed you earlier. When we exposed the young pups early in life to DES, they tend to develop more fibroid later in life. And to understand the molecular mechanism of that, we had to isolate the stem cells from the rat, and we did the same from human. So we isolate the stem cells from the normal myometrium. We get it when we do hysterectomy for things like prolapse, when there's no fibroid. And we also, of course, get it from the abnormal myometrium from a fibroid uterus when we do hysterectomy for fibroid. So one of the interesting observations that became clear right away is that African-American women actually have more stem cells in their at-risk myometrium, the myo-F, compared to European American or Caucasian counterparts. And we know from in the tumor biology field, the more stem cells you have, the increased risk of something going wrong and you developing tumor. So that could be another factor why fibroids is are more common in African American. Now, of course, with the stem cell in hand, we were able to do kind of hardcore basic science work using next generation sequencing and ask some really interesting questions. So for the sake of time, I'm not gonna dive deeper into this, but just to kind of tell you in general terms, we found that the stem cell, the genomic profile of the stem cells from the myo-F, the myometrium adjacent to the fibroid, behave in a very similar way to the fibroid, while it's actually so different from the real healthy myometrium. So we have this kind of interim status, the myo-F, the at-risk myometrium, that is kind of sitting there during early life, teenage years, early adulthood, and waiting for that second hit that I presented to you earlier. So to put all of this together, we have this working model. We think chronic inflammation is as a major central player that kind of gel or tie all of these factors together. These are the same risk factors that I covered in the last 20 minutes or so. We think they all merge into causing chronic inflammation. This chronic inflammation, if it goes unchecked, if we don't reverse these risk factors, end up causing DNA damage and impaired DNA repair, which could create the microenvironment that's very conducive of the appearance of the MYT12 mutation. And once you develop the mutation, then fibroid is going to happen. And I'm going to finish now by just touching on some future direction, some of the knowledge gaps in the field. We still don't have full understanding of why fibroids are more common in women of color. Also, we need better understanding of how the adverse environmental exposure lead to fibroid. Some of the exciting things that we are doing in the lab and other groups as well, we try now to understand how the uterine fibroids cause heavy bleeding. How does it talk to the endometrium? Because the endometrium is the layer that actually bleeds. And we think that they talk together using these vesicles called exosomes that comes from the fibroid and have an effect on the endometrium. I'm happy to discuss this more and show you data, some new data from our lab in the discussion period. Also, uterine microbiome is a new exciting area of research. Epitranscriptomics. We definitely need fertility-friendly therapy. Dr. Stewart will cover the different treatment options, and you will see that we have very limited treatment options for women who are suffering from fibroid, but they're also trying to get pregnant to be able to tackle the two challenges at the same time. And of course, I'm very fascinated and excited about the potential, once we have better understanding of all of these items, to develop prevention strategies. Instead of waiting until the fibroid develop and try to treat it, we probably now and in the future definitely will have more understanding that will allow us to prevent the development. So this is my last slide. I'd like to thank my wonderful team here. Most of them contributed to this work. And I'd like to thank NIH for funding our fibroid program for the last 20 years or so. Thank you so much.
So thank you so much for a very, very interesting discussion. I think we've learned how complex fibroids really are. One of the things that it struck me as you were talking is you put up a slide about future directions. And I'm wondering if you could let us know a little bit more about the immediate future direction I think we need to go in. One of the next questions, which is very important, people want to know, can fibroids grow quickly? And what's the scientific explanation about why fibroids are so different and why some people have multiple fibroids and why they seem to grow at different rates?
Right. So that's another very interesting question. So from the work from the NIHS, Donna Bird and others, so she published that a few years ago when she did an MRI on women with fibroid for about 6 months and followed clearly what happens in the same uterus, in the same patient. It turned out that actually for the first time we appreciate that in the same uterus, some fibroid grow, some fibroid actually stay constant, and some actually shrink without any treatment. So that kind of create an interesting observation. It turned out also that there's some ethnic difference there. So for example, in African American women, fibroids tend to grow until the age of menopause. Okay, as we all know, fibroids tend to stop growing and actually start to shrink at the age of menopause, because the estrogen and progesterone that's coming from the ovary stop at that time. And these are the lifeline of fibroid. But even before that, it turns out that in Caucasian women, fibroid tend to slow and actually tend to stop growing before the person reaches menopause, roughly around 45 years of age or so. While in African American, they continue to grow until the age of menopause. The explanation, I guess we need more understanding of this, but some of the factors that I mentioned, for example, vitamin D deficiency is much more common in African American women. And we have seen in the lab and in animal models and in actually some preliminary data in human, the more severe vitamin D deficient you are, the bigger and the faster your fibroid will grow. Now, as far as why some individuals end up with one lesion versus multiple, again, we don't have full understanding of this, but some preliminary data we have from the work that I've presented on the stem cells, it turned out that African American, again, tends to have more stem cells in their uterus, and they tend to be more in the fundus region, in the top part of the uterus. And wherever you have more stem cells, there's going to be increased risk of you developing fibroid, because these stem cells are the origin cells of the fibroid. So that could be also contributing why African American tends to have multiple lesions of fibroid, while Caucasian usually have fewer number or actually a single fibroid.
So then we have another series of questions, and I'm going to put them sort of together. It has to do with why some women who have fibroids have difficulty getting pregnant. Is there some effect on the endometrium? And then along with that is the question of why is it some people ask the question that they know women who have many children and they don't seem to have fibroids, or after pregnancy, fibroids seem to be not so much of a problem. Can you explain that?
Yes, this is, and I'd like to thank those who asked this question. Very interesting questions. So let me answer the first part first, the fertility. So fibroid, the relationship between fibroid and infertility is considered an association, not necessarily a cause and effect, because there are women who has fibroid who get pregnant easily without any medical help, and there are those who don't. So it's considered an association. Clearly, women who has fibroid, let's say if we take 100 women with fibroid, 100 women without fibroid, we'll find more infertile women, or women with fibroid will have harder time. But it's not an absolute relation. It's not like, for example, if your fallopian tubes are closed and blocked, then you cannot get pregnant. Now, we don't fully, again, understand how fibroid causes infertility. Sometimes it's very easy. It depends on the location. Like if the fibroid is blocking your tubes, your fallopian tubes, that's the tube that the sperm needs to meet the egg, then the sperm cannot meet the egg. And if they cannot, then you cannot get pregnant. But most of the time, that's not the case. So we believe that it is those exosomes, it's those factors that the fibroids secrete and send to affect the endometrium. And the endometrium, as I described in my slides, is the layer that the embryo gets implanted on. So if this layer is not a nice kind of suitable soil for the embryo to implant, then you cannot get pregnant. And also, even if you get pregnant, that also might contribute to the increased risk of miscarriage and so on. So it's those exosomes or those factors that's secreted from the fibroid to affect the endometrium. And I just want to mention here that we're doing actually an interesting study funded by the NIH to evaluate the ability of green tea to treat women with fibroid and infertility and unexplained infertility. This is an ongoing study right now, and anybody who's interested can look up my name under in clinicaltrials.gov. This is an NIH-funded study. And then quickly about the last part of your question, yes, pregnancy actually changed the biology of fibroid dramatically, especially in the postpartum period and after you deliver, because the uterus grows quite a bit during pregnancy, about 50 times, and then it has to go back to the normal size. So all of this remodeling, and of course, Dr. Lippert is the expert on that, all of this remodeling of the myometrium, if you actually have small fibroid, less than 4 centimeters, they tend to actually disappear. As the uterus gets smaller, they call it uterine involution. It's almost like the small fibroid gets refurbished into a normal myometrium. And even the bigger one, more than 4 centimeters, they tend to get smaller. So yes, healthy pregnancy and delivery actually changed the biology of fibroid dramatically, and many women tend to have mild disease afterwards or no symptoms at all.
Thank you very much. Another question has to do with vitamin D. You know, vitamin D is in the sun, and this may seem like a simplistic question, but how long do people have to stay in the sun in order to get enough vitamin D to help with fibroids? We don't know.
Yeah, that's a realistic kind of practical question. And as I start to study vitamin D and fibroid, I start to talk to those who are really expert in vitamin D biology for their lifetime work. And it turned out that it's not easy. So not only how long, but also what kind of sun. It turns out that the early day, like the best amount of ultraviolet you get is actually when the sun first come up. So, you know, it depends where you are, obviously, let's say between 5 and 7 or so. And then you have to have a lot of skin exposure. So I'm in Chicago, so you can understand the challenge to hit the 5 a.m. to 7 a.m. time with very little skin coverage in the winter. That's not practical. So the short answer is really difficult. So we're going to have to really rely on vitamin D supplement. And according to the Endocrine Society, most of us actually should check our serum vitamin D levels regularly. And if we are vitamin D deficient, the normal range based on the Endocrine Society is 30 nanogram to 80 nanogram per ml. If you are not in that range, if you're less than 30, then the Endocrine Society recommend fixing that and correcting your vitamin D deficiency.
Thank you very much. There's another question that had to do with the shear wave elastography. Is that procedure available in many hospitals, and how do you think it might work in the future?
Right. This is such a super exciting area, really, that can, I would consider it a paradigm shift in our practice. It's not really a different machine. It's just you need an extra piece of equipment to attach to your regular ultrasound. So the good news for all of us gynecologists, we're used to use ultrasound a lot. So it's not like a major technological change. It's an extra piece that you can buy to attach. And from the patient side, it will feel just like a regular ultrasound. The probe looks exactly the same. The way we do the ultrasound is exactly the same. It's just the technology will capture more information. I'm aware of definitely several centers who have it in the US and Canada. Like I mentioned, Dr. Sonny Singh has been pioneer in this area in Canada, and hopefully he might touch on that in his presentation tomorrow. So I would encourage you to tune in. It's a simple technology to adapt. And talking to my ultrasound colleagues who are really expert in that, it's not difficult to adapt. I think it's a major important role and a tool, I should say, that will have a role in our to take better care of our patient, because the stiffness of the fibroid will tell us a lot more information about the biology of this tumor, much more than what we have now. All what we have now is really the location and the size. And we know that correlate very poorly with the patient's symptoms. I believe the SWE and the stiffness of the fibroid will be able to tell us much more.
Thank you for that interesting answer. And now there's a question, and I'm trying to see how I can rephrase this. The question is, how young can a woman be to develop fibroids? Do we know? And are more younger people getting fibroids? And if so, how should we follow them or treat them?
Right. So yeah, that's another very important question. So in principle, you cannot develop fibroid before menarche, before you have your first menses, basically because what we talked about earlier, that fibroid lifeline is estrogen and progesterone. These are the hormones that comes from your ovary when you start to go into adolescence. The ovary before that, the average age of menarche, that actually varies between different ethnic groups and so on. But let's say roughly between 10 to 12 years of age, that's usually when young girls start to have their first period. Before that, the ovary doesn't actually produce any estrogen and progesterone. So there's no chance for you to develop fibroid. And sure enough, there's no recorded fibroid before this age. Once you start the ovary start producing estrogen and progesterone, then if you have these other risk factors and this priming that I talked about, that's when your risk to develop fibroids start to go up. Definitely African American or Black teens can develop fibroid. Dr. Erica Marsh actually did excellent work on this when she actually was here in Chicago. She's in Michigan right now, but she did some community work, ultrasound screening, asymptomatic, healthy individuals to look at the fibroid prevalence. And she found that African Americans tend to develop fibroid earlier, as young as 17, 18 years of age. Again, European American and other ethnic groups tends to develop it much later. Now, as we talked about earlier, not everybody who has fibroid will actually have symptoms. Roughly around 50% of those will have symptoms. At this point, unfortunately, we have no way of predicting. Like if somebody gets an ultrasound done for other reason, let's say they have a pelvic pain or some other reason, and we see fibroid, but they are totally asymptomatic, and I'm sitting with her in the office, I have no way of telling her if she's going to develop symptoms or if she's going to be from the 50% that's not going to develop symptoms ever. And as you can imagine, this is very important to decide if you want to do something about it or not. That's another area where I think the elastography, that special kind of ultrasound, might help us predict that based on the stiffness. What I'm doing now is I check them for vitamin D. If they are deficient, I encourage them to correct their vitamin D deficiency. I counsel them in general about all these other things that we talked about, lifestyle changes. Alcohol consumption is a risk factor, obesity is a risk factor. So I mention all of that. And then usually we do watchful observation. And typically I would do an ultrasound every year or so, or ask them to come back when they have symptoms such as heavy menstrual bleeding and so on.
So you talked a lot about prevention, and granted, we don't know a whole lot right now, but what would you suggest that people can do in order to really sort of prevent or help fibroids from growing right now?
Absolutely. This is a very important topic, and I hope some of our viewers who are interested in this area, you actually pay more attention to that. It's such a common disease. If you look at the numbers, at any point of time in the US alone, roughly, nobody knows the exact number, but roughly there's like 35, 40 million women with fibroid. As you know, the incidence by the age of 50 is about 70% in European American, 80% in African American. So almost everybody will have fibroid. As of course, all of us, you fellas and others, practicing gynecologists, most of what we do is fibroid. It's such a common disease. When you have such a common condition, really prevention becomes a very attractive goal. So at the moment, from the list that I showed you, we really have pretty good idea who have an increased risk of fibroid based on ethnic and racial background, based on vitamin D deficiency, the weight issue, some polymorphic markers, all of that. So we can develop already models to identify those who have increased risk before they develop the fibroid. Of course, more understanding will even refine that model even more. Now, once we identify those who have increased risk, then what can we do? If there's nothing to do, obviously that becomes a futile kind of effort, but there's stuff we can do. For example, the vitamin D deficiency, again, I'm very keen on that. And many of my colleagues who don't measure vitamin D wonder, like, why I'm measuring vitamin D. I measure vitamin D levels on all my fibroid patients. But then we can do this even earlier, before the patient develops fibroid. We can also start counseling the patient about lifestyle changes, about diet, like the more like diet that has low level of estrogen, like, for example, avoiding soy products and so on. Again, using food that has high level of vitamin D, and of course iron if you start to have symptoms. All of these lifestyle changes and simple things that we can do can actually contribute to the prevention of for the development of the disease, or if you develop disease, will be much later and will be much milder disease.
Okay, that's very helpful, I think, to people, although I know we do have to do more research. Another question is related to the environment and pollution, and they want to know, what are phthalates? And because there's a lot now about that and how they can kind of cause or lead or be a factor in fibroid development. And can you talk a little bit about that?
Absolutely, that's a very important question. So there are many factors in the environment that has been connected to fibroid, mostly centered around material or substance that has kind of worked like the estrogen. So phthalate is one of them. Phthalate, for those who might not know, it's a chemical, artificial chemical, obviously, that's very common in our plastic containers, like my water bottle here, if you can see it. It has phthalate, and many cosmetic products. So I would encourage you to actually read the label and read the ingredients. Dr. Ami Zoma from DC has probably published the best work on the connection between phthalate and fibroid. Very strong connection. So, but there are several others. We talked about DES. Luckily, we don't use DES anymore. Other things like BSA, many different products. So in general, of course, that's part of a more major discussion. Yes, I mean, if you can avoid these estrogen-like compounds in your everyday products and decrease your intake of these products, that will be definitely helpful, especially if you are pregnant or trying to get pregnant, because it seemed like the exposure become much more influential, much more impactful during the uterine development, during the development of the uterus. And it turns out in human, the uterus actually developed while the fetus in utero. In rats and other animals, it's actually the first couple of weeks of life. But in human, it's actually inside the uterus. So women during pregnancy and while trying to get pregnant need to be particularly careful about that. Also, some hair relaxer. Lauren Weiss from Boston has published excellent work on that. Some hair relaxer products actually have estrogenic component and have been connected to fibroid. So I would at least do this at an individual level. Of course, at the society and community level, that's more kind of a bigger discussion. But unfortunately, minority communities tends to have higher risk of exposure to that. Then the last thing I want to say on that particular front is, yes, while ideally avoiding the exposure is the best way to go, our work then trying to understand how does the exposure works, and especially at the epigenetic level, and how does it change the cells in the uterus, and if there's something else we can do to actually reprogram or remove this kind of first hit. For example, we found that special extract from green tea, it's called EGCG, can actually kind of antagonize or reverse the damage that has been happened by this early life exposure. So while we're trying to improve the environment, decrease pollution, decrease exposure, some of the basic science can provide a more quicker and immediate solution at the molecular level by kind of finding if there's simple natural products that we can take to actually reverse that damage that has happened.
Thank you very much. It gets more and more complicated as we learn, I think, more about fibroids, but it is important, and it's an important thing in order to prevent fibroids, not only in our own bodies, but in future generations. We have time for one last question, and I think I'm going to ask you a question that has to do with what you think is the most important aspect of our future research agenda. And we have about 1 minute to say that.
Right. Wow, that's a big question for any time, particularly for 1 minute. But honestly, I'm very encouraged by what's happening in the field. Definitely, we need more research. It seems that there's a lot of interest in fibroid research from the new administration, and the NIH support is crucial for that. And I actually like to congratulate the Fibroid Foundation for some of the behind-the-scene effort they're trying to do to enhance funding for fibroid research. I honestly think, fellas, that God have given us a natural model. This higher prevalence of fibroid in African American or women of color compared to other groups is really like a natural model. And the more we understand this, the more we're going to understand more about the disease. And of course, this better understanding should lead to better prevention strategy and better treatment strategy.
So thank you so very much, Ayman Al-Hendy, for the wonderful, wonderful talk. It's given us a lot to think about. And the questions, the answers to the questions were very helpful. We are very, very grateful to you. Thank you so much.
Thank you so much for having me.
Hello again. I'd like to now introduce Dr. Elizabeth Stewart. Dr. Stewart is a professor of obstetrics and gynecology at the Mayo Clinic in Rochester, Minnesota. Dr. Stewart is also an advisory board member of the Fibroid Foundation. Welcome, Dr. Stewart.
Good afternoon, everybody. I'm Ebby Stewart, and I'm a gynecologist at Mayo Clinic in Rochester, Minnesota. I'd like to thank the Fibroid Foundation and the Campion Fund for hosting this meeting and look forward to talking a lot about fibroids. I've got a pretty broad topic about everything we've learned from clinical practice and clinical studies. So I know we won't be able to cover everything in this small amount of time, but I'm also open to questions on other things that you may want to talk about. And one of the reasons it's so hard to talk about clinical fibroids is there's such a range of size and location and even number of fibroids. So this is a picture from an article we published back in 2015. And up here in the corner, you see a small fibroid in the back wall of the uterus. And I describe this as a pretty small fibroid, but some people come into my office and they've been told by their doctors that this is a big fibroid. This, on the other hand, is what I would consider a big fibroid. It's filling all of the space from her abdominal wall back to her spine. And in fact, she started having leg swelling as her first symptom that brought her fibroids to attention. And you see she's got this second fibroid up here that's causing heavy bleeding. This is a more common kind of fibroid that I see, where there's one huge fibroid that's pressing the normal uterus down right here, but again, pushing the abdomen forward and pushing back on the spine. And then we see fibroid uteruses like this, where there are dozens of fibroids throughout the uterus. So it's a much harder disease to get one treatment option that tells us exactly what we need to do. So the biology makes it difficult. The other thing is that fibroid symptoms are very heterogeneous. And they can be related to other things. So sometimes I see women with a big fibroid pressing on her bladder, but she believes that the reason that she's having to get up every night to pee every hour is because she drinks a lot of water before bedtime. They may both be related, but unless she knows she has the fibroid, then there may be a more common explanation. And a lot of new research has said that, gee, if this is a problem that runs in your family and everybody in your family has 10 days of bleeding, you may feel that that's normal, or that you've always been anemic, or that you have back pain because of your work. So there are a lot of fibroid symptoms that are unrecognized or attributed to other problems. One of the most interesting things I think about fibroid biology that came out of the fibroid growth study at the NIH branch, the NIEHS, is that there's a lot of variability with fibroid growth. So the average growth is about 9% over a 6-month period of time. So this was seen in about 50% of the fibroids. But fibroids can grow very quickly. So in this study, about 138% growth in 6 months. Or there were fibroids that shrank substantially. So that not every fibroid is going to grow and grow and grow. Some may shrink. Some may have growth spurts. And there is some pattern to the growth. That there's a little bit of a difference between Black women and white women, and that there's a much bigger difference when you look at Black and white women who are at least 45, where Black women still tend to have fibroid growth, whereas white women don't, and may even see shrinkage. That this comes into play as we talk to women who are trying to transition to menopause. The other thing is, when you have a single fibroid, it's more likely to be growing than if you have more numerous fibroids. So a lot of things to make predicting fibroid behavior complex. And underneath all of the clinical variation, there's a lot of variation in biology. We now know a lot more about the genetic alterations, and we've talked about those previously. that there are a lot of environmental and lifestyle factors that play into fibroids. There's a lot of difference in how the fibroid looks under the microscope in the extracellular matrix and the way women respond to hormones. Now, we can't yet individualize treatment based on the different biology, but there are a lot of things that are making trying to get to predicting what fibroid treatment is right for you difficult. I think in the future, we're probably going to be better able to use the information we have about biology to treat fibroids long before they get to something that's 5, 10, or even 20 centimeters in size. So I think we know that fibroids develop from stem cells, and then they get to be a pre-fibroid and a preclinical fibroid. And I'm hoping that in the future, we're able to intervene earlier so we never get to these large masses that we see today. But I think if I can leave you with one message today is that almost every woman can have an effective alternative to hysterectomy. So many women walk into the doctor's office and they're told that, I'm sorry, given the size of the fibroid or the number of fibroids or the severe symptoms that you're having, you have to go straight to a hysterectomy. And I firmly believe that that's not true. That there are a couple of different medications. So a lot of them relate to hormones. So birth control pills and medicated IUDs are both options. But even for women who want medical therapy that can't take hormones or don't want to take hormones, they can take tranexamic acid during their period. So using a medication for just a couple of days every month can be effective for some women. We're going to talk a little bit more about GnRH analogs later in this talk, but there's newer ones available. And then there are the traditional surgical options like myomectomy, but there's also new generations of interventional procedures. Uterine artery embolization has been around since the 90s, and radiofrequency ablation and focused ultrasound more from the 2000 era. But I think that if you're being told that there's no option other than hysterectomy, that's the time to be thinking about a second opinion. And I think that we're in a period of rapid change for fibroid therapies because there's many more options now other than birth control. And I put birth control in quotation marks because I think this is a real failing of our field that I think instead of calling them birth control pills or IUDs, that they're really medications to change the steroid hormone balance for gynecologic disease. So some women take birth control pills and have no interest in birth control, but it stabilizes their estrogen and progesterone. So I think that that's a missed opportunity. But I think most people are aware of the older generation of medical therapies, the GnRH agonists, and Leuprolide is the most commonly known one here, brand name Lupron. They were given as shots, and that before they turned off the estrogen and progesterone, they increased the hormones. So that was a problem from symptoms and even heavy bleeding. The medications were used alone, and so you were aiming for menopausal hormone levels. So symptoms like hot flashes, bone loss were really common. So these drugs are very effective fibroid therapies, but it's really the symptoms that kept women from using them longer term. But there's now a new generation of GnRH modulating drugs, and these are called GnRH antagonists. And the three that are most advanced in terms of clinical development are elagolix, relagolix, and linzagolix. And these are pills rather than shots. They have the advantage that they shut the reproductive system down right away, so you don't have this flare. And at least the first two in this group, the way they are being studied and planned to be used is you combine the medication with a very low dose of estrogen and progesterone. So you're aiming for low normal hormone levels. And this really is a major game changer in terms of symptoms, so that you don't have the hot flashes that limit your ability to take the medication, or the bone loss that make it medically a problem for you to continue the medication. And the first drug that was reported on for uterine fibroids is elagolix. And this is data that came out just about a year ago. And you found that the women in this trial who took placebo less than 10% got improvement in their heavy menstrual bleeding. So this is the primary endpoint of the trial. So it represents both an absolute and a relative decrease in the bleeding. And you found that in the first trial, using just the elagolix medication, 84% of women had this two-step improvement in their bleeding, and nearly 70% in this first trial had improvement when you added back the low-dose estrogen and progesterone. But interestingly, in the second study, and all of these medications have to go through 2 different studies to be FDA approved, you find that they are equal in terms of their effectiveness. So elagolix also found that there were other bleeding endpoints that were significant in both trials, and found that they were more likely than placebo to correct anemia if you had anemia at the start of the study. So this drug, the combination of elagolix plus estradiol and norethindrone, is actually now FDA approved for the treatment of uterine fibroids for up to 24 months. So since May, we've been able to use this treatment for fibroids. A more recent publication that came out in January tried to look back through this trial data to say, is there a subgroup that really doesn't respond to elagolix? And the nice answer is no. Whether you had higher than the average bleeding or lower than the average bleeding, both groups responded. No matter what kind of fibroids you had, they all responded to elagolix. Again, it was nice to see that if your uterus was bigger than average, you had even more of a response than if you had a less than average size uterus. Same thing for the fibroid. The bigger fibroids had a more significant response with the medication than the other. So it's looking like right now there's no specific size or type or blood flow that won't respond to these medications. And the second drug, relagolix, actually just had their data published last Thursday. So this is data that's hot off the press. So again, in these 2 studies looking at relagolix for fibroids, there was a little bit more of a response with the placebo than in the last group. But again, you saw similar patterns that you saw in yellow, relagolix with estrogen and progesterone giving you very similar responses to the drug alone, which causes heavy menstruation, which is associated with those low estrogen symptoms. And one of the most exciting parts of this study for me was that not only did you see correction in the bleeding parameters like we saw with elagolix, but that they looked at additional what we call bulk-related symptoms or pain-related symptoms. And we found that even with the combination of the relagolix and the combination therapy with estrogen and progesterone, there was also a decrease in pelvic discomfort, There was a substantial decrease in pain, less than 1, so virtually no pain over the last 35 days of treatment, and a decrease in uterine volume. So only the decrease in the volume of the largest fibroid was not significant with relugolix combination therapy. So I think more and more women are going to be seeing a effective medical treatment in the future. I wanted to talk for a few minutes about uterine artery embolization, which I believe is a way underused treatment for uterine fibroids. This is a diagram of how it works. You make a small incision right where the leg meets the trunk, and you use a catheter to deliver little pellets that block off the blood supply to the fibroid. And so the nice thing is that this kind of treatment, you can treat 12 fibroids just as efficiently as you can treat 1 fibroid. So there's a lot of data showing that UAE is an effective fibroid treatment. There's been nearly 8,000 women studied in trials. And there's high quality evidence that uterine artery embolization results in volume reduction and bleeding reduction, and a moderate quality of evidence that your quality of life is improved with uterine artery embolization. I think a lot of women that are considering therapy with multiple fibroids are trying to decide, should I have a UAE or a myomectomy? And I think one of the key things that we often forget about is that the risk of transfusion is markedly reduced with UAE versus myomectomy. And since many women with fibroids are severely anemic going into treatment, this can be an important deciding point. UAE also has more rapid recovery than myomectomy, and it has fewer major complications, but increased minor complications. And there may even be a problem with this comparison because at the time most of these trials were done, women with UAE were going home within a day or two of the procedure, whereas women were with myomectomy were in the hospital. So calling your doctor, coming back and being seen was considered minor complications in some of these studies. There's also been a lot of concern about maybe UAE not being as good an option for women who want to get pregnant. And there was a big clinical trial done in the United Kingdom called the FEM trial. It was published in the New England Journal last July. And although the numbers were small, the number of pregnancies and the number of live births were higher in the UAE group than the myomectomy group. Now, the women in this trial were older than some other trials. The average age was 40. And so that probably relates to the number of pregnancies. But I think for me, it's causing me to consider UAE as a pregnancy sparing option for some women as well. We're also getting new information on fibroids from the Compare UF Fibroid Registry, that there were a number of sites throughout the US that participated in this trial. And for example, this is one of the papers where we were looking at how women were doing a year after myomectomy versus hysterectomy. And that there was, in general, improvement in health-related quality of life that showed hysterectomy was better, except when you did an abdominal myomectomy versus an abdominal hysterectomy. And again, this is the boat that many women are in when they have big fibroids. So understanding what causes this difference is important to deciding which therapy is right for which woman. We're also learning a lot about myomectomy, or taking the fibroids out but retaining the uterus. And abdominal myomectomy can be done for any size fibroid. So we've sometimes done myomectomies for fibroids that are as big as a woman who's about ready to deliver her baby. For smaller fibroids or for smaller numbers of fibroids, you can sometimes take them out with a laparoscope or a robot. And sometimes you can take fibroids out without an incision by going through this vagina and cervix into the uterus and taking the fibroid out in pieces. So here's a picture of the fibroid before we started, and here's a piece of the pieces that we'll take out through the vagina. And so I think that this data from Compare UF shows that it doesn't matter how big the fibroid is. In this study, before the myomectomy, whether it was done with a hysteroscope, a laparoscope, or with a big abdominal incision, all women had severe symptoms. So 50 out of 100 is considered severe fibroid symptoms. Between 78 and 92% of women have bleeding problems, and between 60 and 85% of women had bulk symptoms. And again, the quality of life was impaired. So just because you have a small fibroid doesn't mean that it's having a small impact on your symptoms or your quality of life. And this was interesting data published in another paper from Compare UF that again looked at the 3 kinds of myomectomy and showed that before and after surgery for each group, we got substantial decrease in symptoms, both heavy menstrual bleeding and bulk symptoms. So even when the fibroid is small and it can be taken out with a hysteroscope inside the uterus, it does result in improvement in bleeding. But it was interesting that we didn't see improvement in any of these routes in terms of pain. So again, thinking about this new generation of GnRH antagonists for the woman who has pain, that this may be an ideal starting therapy. So I listed the publications that are available right now from Compare UF. There's a number of other publications that are still being finalized. So over the next year, you'll see more of these. But this is one of those studies that is telling us a lot about the treatments that we use every day. And again, coming back to the theme of hysterectomy, while hysterectomy eliminates new fibroid formation, it's not a risk-free option. And this is a topic many women are not hearing about. So many women consider having a hysterectomy when they've had severe fibroids the best day of their life. But there are other women who strongly wanted uterine conserving therapy and didn't get options. And although the symptoms improve, there's now data that shows that there are long-term side effects. And I think many women don't know these statistics, that your lifetime risk for hysterectomy in the United States is about 45%. So of all of the women listening in today, almost half will end up having a hysterectomy unless these statistics change. And only 8% are for cancers. So when you take all kinds of cancers together, that accounts for 8%. And fibroids account for at least a third of all hysterectomies and maybe up to half. And our practice has changed over the past decade, that many women used to have their ovaries taken out because it could prevent ovarian cancer. And thanks to work done by Bill Parker and others, that we found that while there was a benefit in decreased breast cancer and decreased ovarian cancer from taking the ovaries out, over on this side, which favors ovarian conservation or keeping the ovaries, most of the data showed that because things like colon cancer and coronary artery disease and stroke were much more common, that there was actually a very big downside to taking your ovaries out. And in fact, that more women died from taking out their ovaries that would have not had specific disease if they had had their ovaries conserved. So I think most women that do elect a fibroid hysterectomy keep their ovaries based on this data. But even when you keep both ovaries, some research we've been doing and that of others is showing that there may be risks. So we've been following women in Olmsted County, Massachusetts, or Minnesota for 20 years and find that even if you have a hysterectomy and keep both ovaries, you have about a 13% increased risk of hypertension, a 14% increased risk of having abnormal lipids, cholesterol problems, a 17% increased risk of heart rhythm problems, an 18% risk of obesity, and a 33% risk of coronary artery disease, or the leading cause of heart attack. So this is really worrisome data that women need to be aware of, that while women are happy with their symptom relief, that you want to be looking not just 5 and 10 years down the road, but 20 and even 30 and 40 years, because many women having hysterectomy for fibroids are in their 30s or 40s. And so if they live to be 80, that's a long-term risk that we don't even have enough time to follow. We're also finding that some women and their childhood experiences of abuse, whether it's sexual or physical abuse, can be linked to removal of the ovaries, and trying to understand those long-term impacts are important. And so this is a figure that we made looking at the risk of hysterectomy with ovarian conservation. So you definitely get symptomatic improvement with fibroids, decrease in uterine and cervical cancer and lung cancer, but there's increasing evidence that other things that we thought were not related to hysterectomy may be increased. So that's just an introduction of information about some of the things we know about fibroids and fibroid treatments. But I know that this group will have lots of questions and want to explore other areas. So thank you for your attention and look forward to the rest of the conference.
Good afternoon.
Hi, Dr. Stewart. How are you today?
Very good, thank you.
Thanks for being here. I'm so excited. I, as usual, got lots of insights from your talk, so I appreciate you delving so deeply into the research in your practice. And I know that our listeners got a lot out of it, and I have a ton of questions, so I'll just start off. Okay. So you touched on bulk symptoms, and I think that term bulk symptoms is somewhat of a mystery to many women. They may be enduring them, but aren't particularly sure what it is exactly. Can you describe bulk symptoms in a little bit more detail and like how that might display?
Yeah, so I think that's a great question, and I think it's a big change in the research community as well. We used to just focus on heavy menstrual bleeding as the only important symptom, but when the fibroids enlarge, they can press on the bowel, they can press on the bladder, they can make you look pregnant when you're not. You can have feelings of heaviness and discomfort. Sometimes you have severe pain, but other times it's a more chronic type of pain. And so there's a lot more to fibroids than just heavy menstrual bleeding. And the other thing about bulk symptoms is that they can be there every day of the month. Now, some of them do get worse at certain points in your menstrual cycle, but they can occur any day of the month. And they also, again, are kind of common things. So sometimes they get ignored, that you say, well, I've gained a little weight and my clothes aren't fitting. And so people will say, well, try losing a couple of pounds and don't even investigate. Is it the fibroid? The pressure and the discomfort are just things many women have had so long that they just feel like they have to live with it.
I appreciate that explanation, and I think it's very helpful. I think my takeaway would be to just really not glaze over anything that's happening in your body and just try to pay close attention to those types of symptoms. So as a follow-up question to that, as you describe the architecture, if you will, of the pelvis, when women are experiencing heavy menstrual bleeding, there's so many things taking place that can take place, I will say, not with every patient, but for some patients like me who experience heavy menstrual bleeding, it's so painful. And I think one of the questions before I came to know more was why, what is taking place with the arteries and the pain that you feel through your legs and your pelvis that makes you just feel so awful when we're experiencing heavy menstrual bleeding and losing a lot of blood. I know that's a layered question.
Well, and I think we don't have a complete answer because we haven't done a lot of research on fibroid-related pain. So I think that's why it was so exciting to see the recent paper on relugolix, to see that pain was an important endpoint of that trial as well. So I think that there's a couple of things going on. So most women, even without fibroids, have some pain with their menstrual cycles. So there are certain molecules like prostaglandins that are involved in shedding of the uterine lining. So part of it is that. That there also appears to be an element of ischemia or loss of blood supply. So when the top layer of the uterine lining is shed, the arteries that supply it kind of go into spasm. So some women feel kind of a twisting kind of pain that I've sometimes called like a heart attack in your uterus. People kind of get the sense of what a heart attack is supposed to feel like, with pressure and sometimes squeezing pain. And there is some evidence that parts of the uterus don't get good blood supply during menstruation. The other thing is women with fibroids often pass clots that are pretty big in size. So just like women in labor have their cervix dilate and get pain when they have the cervix opening and something going through it, that can be part of the pain and the discomfort. And there's also contractions in the uterus. So just like contractions of labor can be felt. So I think that there's a lot of things that are going on in the uterus, and we've really concentrated more on the study of bleeding than we have on the pain related to fibroids. But I think it's something we need to pay more attention to, and to validate that women do have lots of different kinds of pain related to fibroids.
That's tremendously helpful, and I would like to bookmark for future discussions your comment on contractions and the impact of the cervix expanding for clots, because I know that pain is just tremendous. So thank you for that. So one of our questions from online was, does having multiple myomectomies affect fertility?
Yes, it probably does. So, and that's a real tough question. We didn't even get into the relationship between fibroids and pregnancy. So sometimes fibroids contribute to problems getting pregnant. Sometimes fibroid treatments contribute to not getting pregnant. And that there's some evidence that suggests that women are have improved fertility after a myomectomy, but not always. And I think that's one of the reasons why those of us that are fertility specialists and fibroid specialists are really trying to minimize the number of surgeries that we do and coordinate them with a woman's reproductive life plan. I think instead of just going in and automatically taking out fibroids surgically, we need to be looking at where she is in her reproductive lifespan, how important is pregnancy, how far away from thinking about pregnancy is she? Can we use something like a medication or a conservative procedure to temporize? So I think that there's a lot more that we can be doing, because I think that's one of the most difficult clinical scenarios for me to see is a woman who walks into my office. She's already had a couple of myomectomies. It's now that she wants to get pregnant and she's still got new fibroids. So unfortunately, surgery can eliminate fibroids that are there, but fibroids are not like the appendix. You don't take it out once and you're over and done with it, that it's more of a chronic problem, and trying to get your reproductive plans together with your fibroid plans is really critical.
That's helpful as well. I know you touched on fibroid growth and size as you approach menopause, and I think many may have the perception that fibroids just go away after menopause. Can you speak a little bit to managing fibroid symptoms through menopause, and if there's anything that women who maintain their uterus and have fibroids as they experience menopause, if there's anything that they should maybe look out for as it relates to, their feelings or symptoms that they may or may not have?
Yeah, since menopause by definition is not having periods, if your only fibroid symptom is heavy menstrual periods, if you can make it to menopause, then your problems are going to be solved. So I think that it's harder when you have pain or pressure, bulk, because the fibroids don't go away at menopause. They tend to shrink, and that's something that occurs over time. And there's some variability in how much shrinkage that you get. Some women get a lot, some women get none. And as I showed in that picture from the fibroid growth study, and Dr. Hendy alluded to it in his talk, there's a difference in pattern between Black women and white women. The growth of fibroids really starts to slow in white women as they approach menopause, but not so much in Black women. So I think that trying to figure out, is there a uterine sparing treatment option that can tide you over to menopause, is a good question to be answering. And again, having good medical therapy is a good place for treatments. Close to menopause, something like a uterine artery embolization can be a good treatment option. Again, for the woman who has just heavy menstrual bleeding, even a medicated IUD may be a good option. But the fact that, again, symptoms are variable is tough. And the second thing is we don't always know when we're going to go into menopause. We kind of get a clue from family history, but I've had a couple of women who are ready to tear their hair out because they've been waiting and waiting and waiting, and they still kept on having that regular period. And I think that's one of the facts of fibroid life that's particularly unfair. Most women assume that if you get your period early, at an early age, you finish early, but that's not the case. If you get your period early, you actually tend to have a menopause that's later. So that is clearly one thing where life is not fair to ladies with fibroids.
I didn't know that. That's very interesting. So for women considering a uterine artery embolization, are there certain, is everyone a candidate? Are there certain considerations that should be made, or certain conversations that they should be having with their provider to make that determination?
Yep. So uterine artery embolization works by cutting off the blood supply to the fibroids. So there are rare women who've had that happen naturally. So if your fibroid doesn't have good blood supply, you're not going to get good relief. The pellets go in the uterine artery. So if you have a fibroid that gets its blood supply from someplace other than the uterine artery, and particularly the cervix. So if you have a big fibroid arising from the cervix, it may not be treated with uterine artery embolization. That there are some fibroids that are so big that the symptom relief is decreased and the complication rate is increased. So I think you need to take that into consideration. And you also have to look at your age and, again, your plans for reproduction. That for women 45 and older, they may find that going through UAE tips them into menopause. And again, for some women, they want their natural hormones around as long as they can. Other women are having such heavy bleeding that being tipped into menopause, if they're already 52 or 53, sounds like a good idea. So I think that that's important. And then I think the area of pregnancy is controversial. That, again, most people still say that women who want a future pregnancy shouldn't be going in the direction of uterine artery embolization. But there are thousands of women that have had successful deliveries following UAE. And again, some newer comparative data, like from the FEM trial, suggests that the success may even be similar to myomectomy. So I think it clearly requires a complex discussion, but I don't think it's an option that is completely closed off from the beginning for the woman who wants pregnancy.
Okay, that's good to know. So I have you mentioned emotions around fibroids, and I think that topic is so incredibly important, and it's not really explored. I just wondered if you could talk a little bit more about some of the things outside of the pelvic symptoms that we're experiencing, like pica, or other reactions that we have to the heavy menstrual bleeding and blood loss, and that really impact those emotions, because a lot of our viewers reach out to us asking if they're by themselves, if anyone else is experiencing these symptoms, and they feel very isolated and alone. And I just wondered if you could speak a little bit to the high percentages of women experiencing fibroid symptoms, and as a result, the emotional toll that it may or may not take.
Yeah. So I think that's a great question. And I think there's actually two elements to it. So the first, is what you've suggested, is that that having fibroids and the pain, the functional impairment, the limitation of your activities can certainly lead to emotional symptoms. And again, it's not published yet, but there's some work on that coming out of Compare UF. So Dr. Nicholson may talk about it a little bit tomorrow. Is that does anxiety and fibroid, or anxiety and depression in women with fibroids get better when the fibroids are effectively treated? So I think that that's one of the key questions we've been looking at in that study. And you mentioned specifically pica, and I think people don't know what pica is, but it's a reaction to severe anemia where you're so iron deficient that you try to get your body to try to pick up that mineral. And so some people have behaviors where they crave ice and chewing ice, or sometimes even dirt or clay, trying to get to minerals. I think that women sometimes are so anemic that you wonder how they get to and from appointments, to and from work. I once had a lady who came to see me that had such a low blood count, the lab called me and asked me if it was blood, because it looked like it was some other fluid that was diluted. So I think that living with chronic anemia, chronic fatigue, chronic pain causes effects on your work, your personal relationships, your life goals. So I think all of that's important. But there's also another side, in that there's some evidence that emotions and particularly emotional traumas may actually be linked to an increased chance of fibroids. So I mentioned in my talk some of the thing that we're seeing with removal of the ovaries may be related to a history of abuse. There's some data that suggests that experience of racism may be linked to fibroids, and again, may be part of the health disparities of this disease. So I think that that there's a lot of complex interactions, and I think that that's one of the most gratifying things about working with women with uterine fibroids, is that once you can get to an effective treatment for women, they often go, gee, I don't even know how I lived like that. I've been putting up with those symptoms, that it's only now that I've had surgery or had UAE or gone on to medication that I realize how stressed and how terrible I was feeling, and I'm never going there again.
Yeah, I can definitely relate to that sentiment. I know you've done extensive work in disparities, and I wonder if we know why women of African descent have such higher rates of uterine fibroids.
No, we don't. And that's really frustrating that, again, the earliest studies kind of looked at kind of reproductive and lifestyle factors. So things that might differ among races, like age at first pregnancy or things like that. That didn't seem to hold the key. That we then went, and when they started to identify fibroid genes, we thought, well, maybe African women and African American women have different genetics that explains it. And it looks like there's the same set of basic fibroid mutations that are present everywhere from Alabama to Finland, and that it doesn't seem to make a big difference. There may be a little bit of an impact with admixture and looking at percent of African ancestry in some studies. As Dr. Al-Hendy mentioned, vitamin D levels may be part of the issue. And so I too check women with fibroids for vitamin D deficiency. That since I practice in Minnesota, both Black and white women tend to have vitamin D deficiency this time of year, since we're all bundled up to deal with the snow. But I think we don't really understand, and it's probably not one thing. It's probably not just vitamin D, probably not just genetics. It's probably multiple issues between, things like vitamin D, experience of racism, maybe even environmental issues. There's newer data that says environmental estrogens and environmental contaminants may be playing a role in fibroids. So disparities in housing patterns may be part of it as well. So I think it's likely to be multifactorial, but I think trying to make sure that we do study new treatments in populations that are most at risk is really important.
Yeah, and as we continue to analyze all of those factors, because I too truly believe that it's not just one thing. I love that slide that you showed that, kind of pointed toward the future and where we need to really kind of focus before a fibroid even forms. That really was informative to me. We have a question about diet. Is there any evidence that a vegetarian or a vegan diet is helpful to stop fibroids from returning?
So there's actually a lot of dietary information about fibroids, and a lot of it comes from the Black Women's Health Study. So that's one of the nice things, is that a lot of the data is specific for Black women. And nobody has really done an intervention trial where they took women on a more normal diet and put them on a vegan or a vegetarian diet to see if fibroids changed. But if you look at big population-based studies, having a diet rich in fruits and vegetables and low in red meats appears to be linked with decreased fibroid risk. And again, a lot of the stuff that also goes along with decreased risk of heart disease, decreased risk of cancer is good for fibroids as well. So fruits and vegetables are good. Red meat in large amounts is bad. Alcohol in significant amounts can be bad. So I think that healthy diet is good for a lot of things, but I can tell you I've seen also a lot of women with a strict vegetarian or vegan diet that still have significant fibroids. So it's not the only factor.
Yeah. So my last question that we got from online is, how do I know if a new treatment is the right one for me?
I think that's a complex question. You really need to talk to somebody that knows about treatments because, again, your particular symptoms, the size and number of your fibroids, the location of the fibroids, where you are in terms of thinking about pregnancy is important. So I do encourage women to do reading in advance of talking to a doctor so they can say, well, what about the new GnRH antagonists? Are they options for me? Could I have the excessive procedure, which is radio frequency? Why am I not a good candidate for UAE or focused ultrasound? So you don't have to know the answers to those questions, but the more you can ask the questions, the more likely you are to get a full range of treatment options presented.
That's very helpful. And I'm sure that, I know I'm always hanging on to your comments, so I'm sure that our audience probably is doing the same. Dr. Stewart, thank you so much for sharing that important research with us and for answering questions and for being here today. We really appreciate you.
Sounds good. Well, looking forward to tomorrow as well. Thank you for the invitation.
Okay, sure.
We have learned an awful lot today, I think.
We sure have. I thought it was excellent.
Oh, and we've learned about how it is unique, about how people have to ask questions of their doctors. We learned that we don't know everything there is to know about the disparities. I was struck by Dr. Stewart's comments about hysterectomy, that was a very important piece of information and data that I think a lot of women do not know, and that needs to be really expressed to people. I was also interested in the fact that the environment and phytoestrogens and hormonal type of pollutants really can impact fibroids. And this is something we really have to pay attention to. What were some of the things you thought were important? I think the emotional aspects is also.
Yeah, there were so many things. I agree with you that I would love to see more uncovered on the environmental impacts. I think, often I call fibroids a chameleon. Some people have said snowflakes. Snowflakes a better term, I guess. But they're so different for every woman, and I just know in my heart that there's so many different factors that we're going to have to consider as we continue to uncover, the cause of this health concern. And so I agree with you. The hysterectomy information continues to expand. I think we're learning more and more and more about just other considerations that you need to have in terms of hysterectomy, in terms of any treatment option that you decide on. It's good to just really be an informed patient, ask questions ad nauseum, and make sure that you have a provider that's really working with you. And I think one of the things I really want to emphasize to our community watching is that you want a provider that's going to speak with you the way the physicians have taken time to speak with you today. That's going to really inform your particular goals for treatment and really give you a comfort level for seeking treatment with them. I think that is pivotal, that you are given access to all treatment options, not just one, and that you feel like you're in good hands. And I think that's critical.
And I also think it's important for you to be aware that scientists really want to know what you think and what ideas you have, because it's only by working together that we can really do something about this.
I agree. And I'm so appreciative of hosting the summit with you, Dr. Leopard. And I think that day one has been just really informative. We've gotten so many responses, and we look forward to everyone listening, following up and letting us know, what resonated with you and how we can improve your experience for tomorrow and moving forward. And so, yeah, this has been awesome.
And we look forward to seeing you tomorrow. Tomorrow, I think there'll be lots of opportunity for discussion. Look forward to seeing you again.
Okay, thanks everyone. Have a wonderful rest of the day, and we will see you tomorrow.
Right.